Hello, my name is Melanie Mora Romero, and I'm going to talk about no sedation or light sedation in critically mechanically ventilated patients. Definition: the practice of sedating patients receiving mechanical ventilation has been standard care. However, trials published in the last 2 decades have reported that the use of sedatives may worsen outcomes in mechanically ventilated patients. A trial comparing daily interruption of sedation with no interruption showed that patients had shorter durations of mechanical ventilation and shorter stay in the intensive care unit with daily interruption. Applications in medicine. A plan of no sedation was associated with more days without mechanical ventilation and a shorter stay in the ICU or hospital than a plan of sedation with daily interruption. The trial was not statistically powered to show a difference in mortality between the trial group, the no sedation group, and the sedation group. A post-hoc analysis showed a lower incidence of acute renal failure in the no sedation group. Pros and cons. Sedation during mechanical ventilation improves patient comfort and may help with ventilator synchronization. However, prolonged and deep sedation has significant side effects, including increased duration of mechanical ventilation, impaired neuromuscular function, and delirium. ICU applied in Ecuador. In the ICUs of Ecuador, there is no uniform way of sedation in patients suffering from IMV, and the frequency and type of secondary complications are unknown. Conclusion: the plan of no sedation results in no important difference in the number of ventilator-free days or in the length of ICU or hospital stay. For mechanically ventilated intensive care unit patients, mortality at 90 days is no different for those randomly assigned to no sedation and those assigned to light sedation with daily interruption, according to a study published.
So as we all know, most of the guidelines, they recommend to sedate any patient who is on mechanical ventilation. And the protocol of awakening the patient daily has been proven to be beneficial in most of the trials that have been published. So the recent practice in most of the ICUs is to sedate the patients and give them sedation vacations daily and see that they awaken. Now, this particular group of authors, they did a study prior in which they looked at a protocol of using no sedation for critically ill patients on mechanical ventilation. It was a single-center study done in Denmark with 428 patients. In this, they concluded that no sedation of critically ill patients receiving mechanical ventilation was associated with an increase in days without trial interventions. The patients in the non-sedation group did not receive any sedative but could receive bolus doses of morphine for analgesia as seemed necessary by the treating team. If it became necessary to sedate a patient, the patients would be given the same medications and similar to the sedation group. And the most important thing that we need to know is that there was a 1:1 nursing patient ratio in most of the participating ICUs. Now, the patients in the sedation group received a continuous infusion of sedatives with the goal of achieving light sedation. That is, to the level at which the patient was arousable, which is usually defined by -2 to -3 on a RASS scale. So they targeted the sedation to -2 to -3 on a RASS scale. Propofol was to be used for sedation in the first 48 hours and was to be replaced by midazolam if it was required to sedate the patient beyond 48 hours. Patients were given a sedation vacation every morning, checked for awakening, and if not to be extubated, they were started on half the dose of sedation that was going on if no signs of agitation. Now, coming to the primary outcome of this particular trial was the 90 days mortality after randomization. So let's look at the sample size calculation. It was done based on this trial which we showed previously. In this, mechanically ventilated ICU patients had a mortality of 36% in non-sedation group and 47% in the sedation group. And they estimated a 5% type 1 error and 20% type 2 error. And they found that they needed around 350 in each group to have 80% power and to show 25% absolute reduction in the risk of death if they wanted to show the difference between the two groups. Now let's see how the study went on. Totally 2,300 patients were assessed for eligibility. Out of these, almost 1,600 were excluded, so a large number of patients were excluded. Almost 1,200 patients did not meet the inclusion criteria, and various other exclusions can also be seen. So ultimately, 710 patients underwent randomization. 354 were assigned to the non-sedation group and 356 were assigned to the sedation. Now let's look at the adverse effects. An incidence of extubation leading to reintubation within 1 hour occurred in 4 patients in the non-sedation group and 1 patient in the sedation group. If the time limit was increased to 24 hours, then it was statistically significant, with almost 31 patients, that is 9% of the patients, requiring reintubation in the non-sedation group, while only 14 patients required reintubation in the sedation group. Even the accidental removal of equipments like NG tube, art line, central line was significantly higher in the non-sedation group, almost 15% compared to 9%. The no sedation group had a higher requirement of morphine in the first 3 days, and the sedation group received more propofol and midazolam. However, the point that is very, very important is almost 27% of patients who were in no sedation group, they received sedation in the first 24 hours because of the various reasons like delirium, agitation and all. So the author's conclusion is that among the mechanically ventilated ICU patients, mortality at day 90 did not differ significantly between those assigned to a plan of no sedation than those assigned to a plan of light sedation with daily interruption. So basically what they wanted to show is that if you give sedation or you do not give sedation, there is no difference in the two groups. Let's look at the strengths. The strength is that it's a multicentric, multinational trial, so can be quite generalized. It has a very strong methodology and a priori publication of trial protocol and statistical plan.